Good morning, everybody. Thanks for joining us today. Hey, it's Rich Westermeyer with Benesmart, and today we're going to be talking about 3 ways to avoid costly health plan incentives. So I'm going to give everybody just about 30 seconds or so to get settled in before I dive into our content for today, because I got a lot to cover. Real quick, while we're waiting for folks to join us, if you're joining us on LinkedIn or on YouTube, I'm just curious to hear from everybody in the crowd. What's the largest health insurance renewal you've ever received at your company? So if you have a moment, drop it in the chat. If you are a consultant, advisor, or vendor on the call, also let me know what's the largest health insurance renewal you've ever seen from a client. So guys, thanks for joining us. Give me just about another 20 seconds or so and we'll get right after it. For those of you that just popped in, quick question for you. If you're joining us online, drop a message in the chat and let me know what's the largest health insurance renewal you've ever seen. Because I think it's about to get crazy. So hopefully you guys have been paying attention to what's going on in the news and hopefully you got a plan in place. But if you don't have a plan in place, rest assured we're going to give you one today. All right. Well, I'm going to go ahead and get after it while those comments are coming in. So our webinar topic for today, again, is 3 ways to avoid costly health plan incentives. So let's go ahead and take a look at just what we're seeing in the news lately. So United States per capita healthcare spending is nearly twice the average of other wealthy countries. You can see we're, about 25%, 33% greater than Switzerland, but we're double that of France, Canada, Belgium, Australia, Ireland, more than double of the UK, Japan, and Italy. So our per capita healthcare spending is really getting out of control. Here's a quick Google search that I did. Healthcare prices 2026 was the nature of the search. So a couple articles that popped up, the price increases that should cause Americans more alarm. This is a KFF Health News article. Really good one to check out if you want to be in the know of what's going on and what's driving the cost increases. Here's another one from the Associated Press. Expect health insurance prices to rise next year, brokers and experts say. Now it's starting to get a little dicey here. This one comes in and says, your health insurance is about to go up by the biggest percentage in 15 years. You can see this one was September 8th, so just earlier this month from Fortune magazine. And this one just kind of drops the bomb from Newsweek. Health insurance premiums could rise more than 80% next year. This one was just dropped last week. So here on the flip side, we have an article from earlier in March from Employee Benefit News. It says how to halt the cycle of healthcare's broken incentives. So that's the good news. And that's what we're going to be talking about today. We're going to talk about how we can unwind some of the misaligned incentives that are actually driving your premiums up. And if you haven't done this before, this is going to be a great exercise for you guys. So make sure you have something to take some notes with. I'm just going to read this real quick because it says healthcare in the U.S. remains trapped in a cycle of rising costs, declining benefits, and a deep misalignment between financial incentives and patient well-being. And that's what we're going to be focusing on today, the financial incentives that are really driving up your plan premiums, probably more than they should. So the true threat to your health plan isn't really inflation or claims or compliance. And yes, those are all threats. So not to downplay those. But if you haven't addressed the way that the system's rewarding the people who are managing your health plan, that's where you want to start. Because everything becomes a little clearer once you clean up these misaligned financial incentives. So it could actually be that the partners that you're relying on to help you manage this spend are what's really driving up your costs. So let's look at some of the components of excess healthcare spending and what's really driving up our spend. So the U.S. pays more in administrative costs of insurance. So 15% additional spend on administrative costs. So those are your fixed costs. So that's definitely something we're going to point out today and something that you're going to want to be focused on. U.S. providers also spend more on administrative activities. So you have the insurance side of things where you're spending more on administrative costs than you should. And then you have the provider side of things where you're spending more on costs than you should. And believe it or not, you can actually make an impact on both of those categories. And those are the top two categories driving the excess spend in your health plan. Third one, prescription drugs. Also a very easily impactable category of your spend is your prescription drug spend. And it has an excess of 10% spend there. Physicians, 10% higher in excess. Registered nurses, 5%. Medical machinery and equipment, 5%. So this is an excess of 60% spend that you can really work to eliminate, I would say, or better manage, let's say 40-ish% of this spend, maybe even close to 50% of this excess spend. So here's what we're going to be focusing on today. 3 components of misaligned incentives. Number one, broker compensation. So we're going to talk about hidden commissions that are inflating your healthcare costs without adding any real value. Network discounts. We're going to look at how networks are pricing claims, and we're going to expose the illusion of savings that networks create. And then finally, we're going to touch on the pharmacy supply chain. So this is a real complex web of middlemen, and you want to work to eliminate as many middlemen in your health insurance as possible. And we're going to show you how to do that today. So starting off with your broker partner, you want to make sure that you're choosing your broker partner wisely. So here we have 2 examples, broker A and broker B. So broker A is compensated based on a percentage of your premiums. So this would be typically found in your fully insured health plan models. And what that might look like is a broker might earn 3%, 4%. I've even seen it as high as 5.5% of your total premium spend. So to put that in perspective, you have $1 million spend, you'd be paying $30,000, $40,000, $55,000 a year in broker compensation. Now, in addition, broker A likely also, if they're paid a percentage of premiums, probably receives bonuses for persistency with the carrier. So retaining that carrier business, and then also for volume with that carrier. So this may be a carrier incentive that's probably not disclosed to you, but should be disclosed to you. And then cost transparency, as I just mentioned, you have limited disclosure of earnings. So under the CAA, the Consolidated Appropriations Act of 2021, the CAA stipulated that brokers are now required to share how they're compensated with their clients. So if you're unaware of how your broker is currently being compensated on any of your benefit spend, this is something that we can help you uncover. It's a really simple email and a form that you request from your broker, but the compensation disclosure is important because you want to know, is this incentive in line with your health plan? So let's talk about how this may be misaligned. Because if your broker is paid a percentage of premiums, their fees increase as your costs rise. So as you end up spending more year after year, as your renewals continually go up, your broker's earning more the more you spend. So that's a fundamental misalignment. Your broker shouldn't be incentivized as your plan costs go up, because what incentive then do they have to help you control those costs? So this is really one of the first steps that you want to take, is to eliminate this misalignment. Now, broker B, on the flip side, they charge a fixed fee. Their fees remain stable regardless of your premium. Now, here at our agency, the way that we operate is we charge a fixed fee based on strategy. So the more complex the strategy that our clients implement, whether it's a captive, self-funded program or a level-funded program, our fee increases based on the complexity of that strategy, because it requires more out of us to help our client manage that spend. So that's truly aligned with the client. And also, our fees aren't going to change from carrier to carrier. No matter what carrier we place you with, you already know what our fees are up front. So you want to look for a broker that offers a fixed fee. Most often, this is going to be a per employee per month fee. If you're in, let's say, the small to mid-size group range, 25 to 250 people on your plan. But sometimes if you get over 250 people on your plan, that's where we might discuss a just flat fee, not per employee per month, but just a flat consulting fee, so that our fees are aligned with your health plan incentives. So no carrier paid incentives or overrides are paid to broker B. And then also full disclosure of all compensation. They profit from delivering value and results. So pro tip here is cut out commission-driven broker compensation. What you're going to want to do is ask your broker for a compensation disclosure to get a better idea of how they're being compensated. So again, in that standard commission model, brokers earn more when premiums rise. This can be anywhere from 3 to 6% of your total premiums, no incentive to reduce costs. And what we have here is a quick example of what this looks like as your premiums go up year after year. Your brokers continually compensated more and more. So guys, you want to work to avoid that as fast as you can. So ask yourself, does your broker get paid more when your plan costs rise? Because if so, you're fundamentally misaligned. So what happens when you save money? Well, if your broker's really doing their job, they're going to work to save you money, work to save your plan money, but then they're going to earn less if they're in that standard commission model. So nobody wants to earn less for doing more, right? So this is why this misalignment is so important to get fixed as soon as possible. And let's hit on some additional broker incentive conflicts. So I talked about these just briefly earlier, but I want to expand on them. So you have premium volume bonuses. This is really going to be something that you see more often than not at what we call your big shops, your large houses, sometimes known as your ABC brokers. So you have Hub, Arthur J. Gallagher, MMA. These larger brokers often will talk about how good of a relationship they have with a carrier, as if that's some type of magic wand that they can wave with the carrier. And the reason why they may be saying this is because oftentimes they place a lot of business with these vertically aligned carriers, these vertically integrated carriers, and they get premium volume bonuses. So the more business they place with that carrier, the more they get paid on the back end. So this is extra payment for maintaining high premium volume across multiple clients. This is, again, misalignment, because then their interest is aligned with the carriers, not necessarily yours. Then we have persistency rewards. So this is a tricky one, because if you've ever felt like your broker may not have presented you with any good options at renewal, sometimes this can be the cause and unknowingly occurring to you. So persistency rewards happen when we get close to the end of the year and these big carriers are looking at their P&L and their stock prices, and they say, well, we need to make sure that we really retain as much of the business that we have on the books today for next year. So that's when they'll start to incentivize brokers with persistency bonuses. And what this might look like is if a broker has a lot of business with the carrier may reach out early on in the quarter to the broker and say, hey, we want to let you know that we have a persistency bonus on the table for you. If you renew 95% of your clients with us this year, we'll pay you an extra $100,000 in a persistency bonus. So this is extra compensation for keeping clients with the same carrier. And this could be one of the reasons why sometimes you feel stuck, like there's not a lot of options. Maybe you're just not being shown the right options. And then you have carrier loyalty overrides as well. So this is additional payments for placing most of the clients with specific carriers, limiting your options. So this can sometimes be found in PEO arrangements where they have a specific carrier that they only do business with. They're likely getting overrides on the entire block of business. So this is also something that should be disclosed. So you want to work to eliminate those conflicts of interest. Don't get stuck on this flywheel, guys. So what you get is, first, you get premium increases, rising healthcare costs, increased premiums. Next, broker compensation increases, commission-based pay rises with premiums, as we already mentioned. And then third, you have no incentives to reduce your costs. So then you really just kind of get stuck on the carrier go round. And there's not a lot you can do about it unless you work to align these incentives. So here's a real life example on a client that we worked with. So the broker incentive really was affecting this client, and they couldn't figure out why there was never any good options presented. So a manufacturer that we were working with had 130 employees on their health plan, and they had stayed with the same carrier for years. This was down in Texas. And every year at renewal, the broker would come in and say, hey, we checked the market. There's just not a lot of good options. And the broker, funny enough, never shared any of the additional proposals with this client. They just presented them with a spreadsheet that said, here's the best options available. Now, this really limits transparency because it's the broker who chose the best options. and the client didn't have an opportunity to see what those other quotes or proposals looked like. And then every year they were seeing the same carriers, the same tired options, and they just kept doing the same thing over and over. What we found out when we first started working with this client is we uncovered that this client was unknowingly paying persistency bonuses through their premiums to this broker. So we worked with the carrier to get an additional proposal, remove those persistency bonuses, and we were able to show the client that even with the same carrier and a different broker, their costs were much lower than with their current broker. So this was a complete lack of transparency. The client had no idea they were paying for these persistency bonuses, and we were able to help this client save thousands of dollars just by switching brokers and not paying that persistency bonus. So here's another article. This is from the end of last year. Employee Benefit News is a great resource for thinking outside of the box, guys. I highly encourage you to check it out if you haven't already been on there. So changing broker mindset would remove a huge obstacle to fixing healthcare. And what we're talking about here is, you have a lot of brokers that have been doing this for a long time, and it's really old hat to them. But unfortunately, some of the strategies that they're employing are very rudimentary strategies to help employers manage their costs. And you guys have probably gone through some of these before, but what I'm talking about is strategies like putting a health savings account in place, a high deductible health plan. All we're doing in that strategy is just shifting the costs around. So instead of the carrier paying the costs, now the member pays the additional costs, right? Everything goes towards the deductible first. Yeah, you may save a little bit of money, but you haven't really impacted any of the plan costs. Another common one that we see with misaligned brokers is moving to high deductible plans, or putting an HRA in place, or just limiting the network in general, putting in a narrow network as a way to save costs, or maybe even removing some of the coinsurance. So going from a 90% coinsurance to an 80% coinsurance. All of these things quietly shift the cost to your employees. Now, they do lower your costs, which I'm sure a lot of you guys have done this or seen that. But at the end of the day, all you're doing is moving the money around and making somebody else pay for it. Where instead, what you should be focusing on is how do you lower the cost of care and how do you remove these misaligned incentives? So here's some simple steps that you can do today to get this box checked and to get this under control. So step one is conduct a broker compensation audit. So just start by asking for full disclosure of broker compensation. Guys, it's your plan. You really, not only do you deserve to know, you need to know how much your broker is being compensated, because you're the one writing the check. You're the one paying their commissions. Next step, once you figure out how your broker is being paid and what your broker is being paid, you want to work to align the incentives. Now, you're not going to be able to do this mid-plan year, so keep that in mind. This is why it's important to understand what these costs are going into renewal. So prior to your renewal, you want to ask these questions. Step two, when you're aligning the incentives, you want to ask your broker if we can shift to a flat fee model. So pay a transparent, pre-negotiated fee regardless of which carrier you choose. Additionally, we've even seen some creative situations where we've worked with clients to put in a performance-based model, or where there's shared success. So some brokers for larger clients are willing to take a lesser upfront PEPM, a lesser upfront fee, in addition to a potential for a back-end payout on percentage of savings. Now, this is tricky to get into and can be challenging to negotiate, but could be very beneficial for your company and something worth exploring if you have over 250 employees on your plan. And then lastly, just eliminating conflicts. So in addition to your broker's compensation, you want to look at how your TPA is being compensated, how your PBM is being compensated, as well as maybe what you're paying for the cost of care to eliminate some of the conflicts where you're overpaying vendors inside of your health plan. So if you want to get some clarity on the hidden incentives in your health plan, shoot me a DM on LinkedIn or YouTube. Just DM me the words review, and I will send you a quick and easy way to ask your broker for their compensation disclosure. I'll even send you a blank copy of our compensation disclosure and an email to send to your broker so you can be prepared for that conversation. All right, next up, we want to unmask the hidden markup in network discounts. So everybody is aware of PPO networks, right? And everybody's a big fan of PPO networks because they provide in-network and out-of-network coverage. And supposedly in our in-network coverage, we get a huge discount on what our plan pays for care. So we want to unpack this. And what we're talking about, if you've ever seen an EOB, which I'm sure we all have, is you see this amount billed, and then you see the deduction or the discounts and the reductions in this next column. And then the amount allowed, and then you see the health plan responsibility. So you got a lot going on here, but this plan billed $78.50 in total claims for surgery, recovery room, lab services, and then applied $3,900 in discounts. Wow, that's a pretty good discount. So 50% reduction in cost right off the top from just being in the Blue Cross network. That's pretty good, right? Well, depends on what the starting point is. And this is really what you have to ask yourself is, do I know what the starting point is of where negotiations began, right? So unfortunately, what we see in the marketplace is that these big name carriers, when they go in to negotiate these PPO discounts, they're already at a disadvantage because the providers on the flip side are starting with their very highest price. So yeah, a 50% discount sounds great on an $8,000 procedure, but shouldn't that procedure maybe have really only been $4,000 in the first place? So this is where you really want to understand, how are these carriers coming to these discounted numbers? So here's another example of a United Healthcare level funded report. So you see here in this example, this client had 166,000 in submitted charges. So that's how much was billed on the insurance. And then we see a $79,000 network discount. So again, that's, greater than 50% discount. And then the plan ended up paying $62,000 for that care. But the question we have to ask ourselves is where do they get this starting price from, right? And why is it so high, and why is it so easy for this PPO network to get a 50% discount? And if we're getting a 50% discount, why are our costs still going up year after year? Think about that for a second. Where else do you go get a service, get half off that service, yet the costs keep going up each year? So discount off of what? Well, the discount comes off of billed charges. These are inflated at the highest level to begin with. And then you get the in-network discount, and then you have the allowed amount. So while everybody's focused on the PPO discount, what most people miss is the PPO discount is really secondary to what you actually are charged in the first place. So for the same procedure, if you were charged a fair and reasonable amount, $4,000, and you only got a 25% discount, well, 50% sounds a lot better than 25%, but again, off of what? So 25% discount off of 4,000, you only paid 3,000 in this instance. So the starting price is a really key component of network discounts, and where a lot of people get tricked into thinking that they're saving a ton. So this is how it works. So networks start from the very top, and then they work to negotiate. Providers start from the very top, and then the PPO networks work to negotiate with those providers. So you might see this in the news sometimes, where a provider system is having network negotiations, and everyone gets worried in that area. Are they going to be able to come to an agreement or not? They almost always come to an agreement, but it's never really in your favor. So you get a 300% markup before the discount's applied. That 300% markup then gets a 50% discount. Well, you're still paying 150% of the cost of that procedure, when the true cost is actually only a third of the discounted price. So how do you get to that true cost? How do you get that true cost in your plan? Well, it's not in a PPO network. I can tell you that much. So again, understanding this is going to be really important, because it's the cost of care that your plan pays that is driving your premiums ultimately. At the end of the day, your premiums are going to be dictated by what your plan pays for care. So there's a great article out there written last year. It's on Benefits Pro. It's the truth behind network discounts. This really helps to expose how network discounts work, and it'll help you be more prepared for your next renewal negotiation. So how would you know if you're actually getting a good deal? Well, you need to start standardizing pricing. And what does that mean? Well, you have to have a good starting point. So here's a good example of why this is important. This is a quick lookup that I did on a surgical procedure to replace a knee joint. Now, the average market price in my area to replace a knee joint is about $14,000, but you can see the lowest insured price was $3,700. So how is it that folks are getting this same procedure with the same CPT code for a fraction of the cost? Well, this is where standardized pricing comes in. So a good example of standardized pricing would be reference-based pricing. So here's a quick reference-based pricing 101 if you're unaware of what this is or how it works. So again, going off hospital billed charges, you have $75,000, and this is what we call top-down pricing. PPO plan offers a 50% discount. That PPO plan ends up paying $37,500 for a knee replacement. Now, we suggest bottom-up pricing instead. So bottom-up pricing works in the reverse. We say, okay, well, what is a standardized price for this procedure? And a good reference for standardized pricing is Medicare reimbursement ratios. So when we talk about Medicare, we're talking about Medicare and Medicaid. Medicare and Medicaid are the single largest payer in our country. About a third of the country receive health insurance through Medicare or Medicaid. Now, on that note, because they're such a large entity, they have the buying power to negotiate prices that are much lower than any other PPO plan. So what we end up with is that knee replacement paid at $15,893. So how is it that this facility, this provider, can charge anywhere from $75,000 to $37,000 for a knee replacement that they're doing for another patient for $16,000? Now, this should really make some of you guys mad, especially if you're the ones writing the check for these health insurance premiums. Because if we have a $16,000 procedure and we work bottom up, well, let's say we know we're not going to get Medicare or Medicaid pricing because, we're a smaller or medium-sized business. We only have a couple hundred folks on our plan. We don't have the same buying power as Medicare and Medicaid, but we could afford to pay 140% of Medicare. And if we did, we're going to standardize our pricing. We're going to say we're going to pay 40% more than Medicare for any procedure out there. We'd end up paying $22,250 for the same knee replacement, which is about $15,000 less than we would be getting it through that PPO network. So this is really going to have a big impact on your plan and ultimately the cost. This is how you save a ton of money, is with bottom-up pricing. So what I'm really trying to point out here is that PPO networks create this illusion of comfort and this illusion of savings. They create illusions of comfort because everybody knows the network. Everybody knows the name. They've done a really good job over the last several decades of marketing themselves, putting themselves in position to be the primary provider in your area, in your backyard, and hence everybody wants them because they're easy to do business with. Guys, I'd be easy to do business with if you were willing to pay me 3 to 4 times what a fair going rate is. I'd make it really easy for you to do business with me. But ultimately, what we're talking about here is how do we eliminate some of these misalignments? And you have to wrap your head around where you're really being overcharged. So that artificial markup to begin with from the providers, the perceived discount from the PPO, in reality, you're still paying more than you should or more than what the procedure is actually worth. So your plan's discounts are following the same deceptive pattern. Here's a real world example. This is a construction company that we worked with, 90 employees. With just 90 employees, they overpaid $7,800 on a single procedure. And we were able to uncover this through claims data. But imagine if this $7,800 overpayment was across all 90 employees. So here's the example. There was a $27,000 hospital bill, original charge for routine outpatient procedure, 60% discount was applied. $10,800 is what the plan actually paid. But a fair price, we found out, was $3,000 because Medicare was paying 1.5. Medicare was paying $1,500 for this $27,000 bill. So this was our baseline. We worked up instead of from the top down. We worked bottom up. We came up with a fair price, which was twice what Medicare paid, negotiated with the provider system, and was able to save this client about $24,000. So here's a couple simple steps for you on networks and what you should do from here. So step one, understand your costs. Stop focusing on the discounts, start focusing on reference points. So a reference point could be Medicare as your baseline. You could also use a price transparency tool to understand these reference points. There's a couple good ones out there. Billy is one, BILLY, price transparency tool. Another great price transparency tool comes from the folks over at Fresh Bennies. So something to check out, but use Medicare as your baseline. This is going to be, again, bottom up pricing. Ignore the discount percentage and figure out how much you're overpaying. Now, this may sound complicated, but in order to do this, all you need is access to your claims data and a broker worth their salt. Because if you get access to your claims data, you can take that claims data and have it repriced with Medicare as the baseline, and you can see how much you're truly overpaying. We recently went through this exercise with a client. Clients located in St. Louis, but they have employees in Illinois and Florida as well. And what we found out is, although there were very few employees in Florida, in the Florida market, they were being billed at about 1,000% of Medicare costs. So 10 times Medicare costs. And this was just one facility. Okay. So this wasn't across the entire state of Florida, but we pinpointed that this member was going to one facility that was charging 10 times Medicare costs. We were able to work with that member to help them understand, hey, not only is the plan paying 10 times the Medicare costs, but that ultimately means that you're paying 10 times what Medicare is paying for that procedure. And we showed the employee what they would be able to save if they found a fair and reasonable provider in their market, and they switched providers immediately. Step two is evaluate network pricing solutions. So I just talked about this just on the last slide. You have price transparency tools. These can be used on the back end of the plan or the front end. So you can use these internally as practitioners, or you can provide these tools to your employees to help them make better decisions. Think about it for a second. When we talk about how we use health insurance and how we get healthcare in our country, it's one of the very few services that we receive the service before we know what we're going to pay, right? And that's really backwards in terms of purchasing something. Almost always, everywhere you go, the prices are listed, you know what you're going to pay. The cashier rings you up at the checkout and your total shows on the screen. And at that point, you have a decision to make. Wow, do I really want to pay $300 for groceries? I know most of us end up paying it anyway, but it gives us an awareness of, hey, we're being charged this, and we have a choice at that moment. Now, in healthcare, on the flip side, you really don't have a lot of choice. When you go into the provider and they say you need surgery, well, they're not going to give you the price of the procedure before you have that surgery, unfortunately. So this is where price transparency tools can be very useful for employees, because if they know they have something coming up and they know they're going to have to meet their deductible, pay their coinsurance, if they have a price transparency tool, they can shop for the best price in their area. It's literally like Gas Buddy. If you guys have ever used Gas Buddy, it shows gas prices around you. They have the same tools for healthcare. Another pricing solution could be direct contracting. Now, we didn't talk about this. We talked about reference-based pricing, so I'm just going to spend a minute on direct contracting. This is a really great way to go about it, because direct contracting works in a way that an employer is able to remove the middleman, i.e. the insurance company, from the equation and work directly with a provider in their area to get lower prices of care. And then you can incentivize your members to go to all of these facilities where you have direct contracting. Quick example of this, we just rolled this out with a client in St. Louis, actually, with the BJC healthcare system. So BJC has a direct to employer contract available, and this direct to employer contract is essentially going to have this client spending 20% less on the cost of care than what the big name carriers in the same market are paying for care. So imagine you have $1 million or $2 million spend, and all of a sudden you have a solution to where you can incentivize your employees to go to certain facilities, and your health claims are 20% lower than what you were paying the year before. This is how you really have an impact on your plan, by eliminating that misaligned incentive of the insurance carrier dictating what your plan spends. So you really want to work to be the one that dictates what your plan spends for care, and not allowing the insurance carrier to be the one negotiating on your behalf, because it's never going to be in your favor. And then lastly, we have reference-based pricing. This is the most aggressive of all three solutions. But I would say, you kind of have the easy solution, price transparency tool, but it's going to have somewhat of an impact in the sense that it's going to open your employees' eyes into how to shop for care. But at the end of the day, what we still haven't done with price transparency tools, if we only put those in place, we haven't given our employees avenues to lower their cost of care. It's just simply a choice at that time. You take the price that you can see. Now, direct contracting gives them an avenue where we've already negotiated the lowest cost of care for that employee, and then they can go to those facilities, and we can reward them for going to those facilities. And then same with reference-based pricing. It's just on the back end instead of on the front end. Here's a screenshot of, this is actually New York, New Jersey. My brother lives in Manhattan, and he was going in for a procedure, and he reached out to me and said, "Hey, Rich, can you help me figure out where the best place to go is?" So you can see just in Manhattan alone, this procedure is anywhere from, call it $15,000 all the way up to $55,000, $88,000. Man, crazy price fluctuations just in a few square miles alone. So important to have access to these tools for your employees, so they're not going to a facility that's charging $55,000 for a procedure that they can get done for $16,000. Think about it, right? Because if your employee's deductible is $2,500, well, yeah, they're going to cover $2,500 of that cost, but they'd also cover $2,500 of that cost. Then the remaining cost is left for the plan to be paid, or with coinsurance. So then when the coinsurance kicks in, the employee obviously doesn't want to pay 10% of what's remaining on the $55,000. They'd rather pay 10% of what's remaining on the $16,000. Your employee wins, your plan wins. So take a deep breath, guys. I know I've shared a lot with you in a short amount of time, and I'm coming close to the time limit here, so I need to jump into the next segment. But take a deep breath, then take a look. So start off with a claims history audit. If you get access to your claims data, this is one of the most powerful tools that you have. Benchmark those claims against Medicare, and then work to find a solution that's going to have you paying lower cost of care. If you're interested in talking about how to implement a strategy like this, DM me review, and we can connect after this meeting and work on a time to get together. All right, so the last thing we're going to hit on, and this is a big one, and this, guys, this is what we call low-hanging fruit, right? If you want to start soft, if you want to start small, start with your pharmacy spend. And this is one of the things that's been creeping up year after year and is only going to get worse, right? Pharmacy spend is literally killing health plans right now. So if you don't have a solution for this yet, you're going to need one very soon. So here we have a screenshot of the PBM supply chain. So we have the drug maker, the manufacturer, who then sells the drugs to a wholesaler, who then negotiates prices with the pharmacy, who then dispenses the drugs to your employees. And all along, the employer is paying for those drugs. The employee just has a copay, right? And we know most of those copays are pretty low. But then you have the PBM, right? This really unnecessary piece in the middle. The PBM, or the pharmacy benefit manager, like Express Scripts or Optum. These companies, when they came out, when they were first introduced, the purpose of a PBM was to help employers control their drug spend. And they've done anything but that over the last several decades. Matter of fact, they're one of the biggest culprits and one of the reasons why our health plans keep getting more and more expensive, because we're just simply paying for their margins. So here's some of the where the margins exist in pharmacy. So you have rebates, right? Everybody probably knows that one. And rebates, I think they've been a hot topic lately. And you hear more and more of these big carriers talking about the rebate sharing that they have available or how good their rebates are. I'll tell you, I heard it best from a client I was consulting with. This company has close to 7,000 members on their plan, and they're with one of the big PBMs owned by a carrier, unfortunately for them. But when they kept talking to their broker about moving to an independent PBM, their broker kept referring back to the rebates. Yeah, but what about the rebates? Yeah, but what about the rebates you'll lose? Well, ultimately, rebates are the wrong area to put your focus, because if you're getting a rebate, that simply says that you already paid too much to begin with, right? Rebates are for when you overpay for a drug, you get money back. And that's just a kickback in that pharmacy supply chain. And that rebate most often goes to the insurer, but should be coming back to the health plan. Now, if you're focused on rebates and you're saying, well, what should I be focused on? Ultimately, what you should be focused on is net lowest cost. Because if net lowest cost for the drug is your true objective, then you're not going to be worried about rebates, because instead of paying $10,000 for a drug, you're going to pay $1,000 for a drug, right? Yeah, paying $10,000 for a drug and then getting a $6,000 rebate sounds great. But if somebody else is paying $1,000 and you only got a $6,000 rebate, you still paid 4 times more than you should have. Then you have the spread. Now, this is just simply margin, and it's another way to say it. So there's a spread where the pharmacy benefit manager will charge your health plan $500 for a drug and then pay the pharmacy $250 for that drug. And they keep the $250. That's their margin. So ultimately, in this equation, what you want to know is, how is your PBM compensated? And in most cases, it's going to be through rebates or through spread. But then there's also administrative fees, direct and indirect remuneration. These are called DIR fees. So this is after a sale and then kind of clawed back from the pharmacy to the PBM. So they're sometimes called clawbacks. There's a lot of hidden fees in your pharmacy spend that you need to be aware of and you need to be evaluating. So again, I just gave an example of how spread works. So in this situation, $10 charged for the drug, $5 paid to the pharmacy, $5 retained by the PBM. In this instance, pass-through pricing means if the plan paid $7 for the drug, $7 goes to the pharmacy. Spread pricing is also another big reason why we've seen a lot of the mom and pop pharmacies struggle to stay in business. Those have been going away with CVS and Walgreens and Costco Pharmacy, and it's because of the spread pricing model. Now, here's another big one, and this is also applies to your pharmacy spend, but you want to pay close attention to your specialty drug spend, because costs for specialty drugs are exploding. 84% increase in specialty drug rebates might have something to do with that. 125% increase in brand drug rebates might have something to do with why we're overpaying for drugs. Here's a little known fact, but specialty drugs only account for about 2% of your overall drug spend. And when we talk about specialty drugs, we're talking about anything that we see advertised on TV, right? And there's a lot more than what's just advertised on TV, but we see them on TV. We see Skyrizi, we see Humira, we see Tremfya, and we see these specialty drugs advertised, and then that name sticks in our brain. And then when our doctor talks about the potential options for treatment, if we've already heard that drug on a commercial, we're going to be more receptive to that drug, more likely to request that drug. And these specialty drugs, while they account for only 2% of prescribed drugs, they account for close to 50% of overall pharmacy spend on your plan. So this is why they are one that you need to be really sure that you have a strategy to combat. Specialty drugs accounted for about half of total prescription drug spending, but represented just 1% of total volume of drugs prescribed. And then there's this whole other hidden enigma inside of the pharmacy benefit manager supply chain, and those are called GPOs. So a GPO is a group purchasing organization, and these really work as rebate aggregators. So we see our big pharmacies here. We have Express Scripts, our big pharmacy benefit managers, Express Scripts, Prime Therapeutics, Optum, CVS, Caremark. And then we see here these rebate aggregators. So in the case of Express Scripts, Prime, and Humana, they've all come together, joined forces under the brand Ascent to form a GPO, or group purchasing organization, to drive bigger rebates within the drug chain. Now, a lot of these GPOs aren't even going to be US-based companies. Even though they're owned by US-based companies, they're going to be formed offshore. So a lot of times you'll see these GPOs are going to be Switzerland-based companies, and this is for liability transfer and as well as protection from lawsuits. So something to watch out for. PBM-led GPO, commercial market share. You can see here that it is the big players that have the largest market share of GPO percentages. So the pharmacy benefit manager trap includes spread pricing, rebate retention, formulary manipulation, and contract complexity. Good luck trying to read a PBM contract, guys. So the hidden markup in reality, this is what it looks like. So you have a drug with a wholesale cost of $20. Your plan is charged $200 for that drug. And the PBM retains $180 in profit. That's a 900% markup. And this happens daily across millions of prescriptions. PBMs are really just margin keepers for health plans. So something you should be aware of. And then the rebate game is definitely something you want to get out of as quickly as possible. Rebate game is where the drug manufacturer offers to pay a rebate anytime one of their drugs is filled on the formulary. And then you're just left guessing what the true cost of that drug is, but you end up paying more. As I mentioned earlier, good luck reading a PBM contract. They're like black boxes, going to be buried with legal jargon, full of vague and hard to define terms, and they're structured to avoid audits. True red flag is whether or not you get access to your pharmacy benefit information. And if you get access to that pharmacy benefit information, you want to know what the wholesale acquisition cost is. You want to know what the rebates are. You want to know if there's any spreads. And if you can't see this information, it's likely because these things are hiding in your plan and they don't want you to see it. Here's a quick search that I did. I just thought it was funny. I'm a big ChatGPT user, but it said, what grade level do I need to read at to understand PBM contracts? And the answer was graduate school level, think grade 16 plus. I mean, it's not because the information is actually that complex. It's because the contracts are intentionally written in dense, legalese heavy language. So guys, I mean, you're going to have a hard time reading your PBM contract from these big name PBMs, and it should be easy to understand exactly how they get paid. Independent PBMs and transparent PBMs are likely going to get paid the same way that a transparent advisor or broker does, and that's going to be a per employee per month fee. So you know exactly how they earn their money, and their scope is clearly defined in terms of how they help you save money. So I'm going to jump ahead here to the 3 steps that you should take on your PBM. Step 1, audit your PBM. So don't settle for a year glossy report that shows you how much you spend. Ask for a full claims report on your pharmacy. And if they don't want to share it with you, they shouldn't be managing your pharmacy spend. We did this exercise last year with a client. They were level funded with Cigna, and we asked for their pharmacy benefit data. And Cigna then requested the client to sign an NDA stating that they wouldn't share this information with anybody. And they also said that it would be a $300 cost for them to get the report. So Cigna wanted the client to pay $300 just to see how much they were being overcharged, but they weren't allowed to share that information with anybody else. Step 2 is after your audit, you're going to want to carve out your PBM. So carve out your PBM out of your plan. That means disintermediate the supply chain. Your PBM shouldn't be chosen buy your health insurance plan. You should be choosing your PBM. At the same time you carve out your PBM, you also want to carve out the specialty meds. So you want to have a separate solution for specialty meds in a lot of cases. So you're going to look for independent PBM, specialty medication sourcing solution, look for transparent PBMs. They're going to be upfront about how they're compensated. And then step 3, before you sign a contract with a new PBM, make sure you demand transparency. Make sure you understand the audit rights that you have, as well as the type of data that you're going to have access to. So you want full audit rights. You want to make sure that you've eliminated spread pricing, and you want to make sure that you're retaining all rebates, if there are any, going to be passed through the plan. So transparent PBMs, regular audits, and carve-out programs are the way to success in the pharmacy world. So just to wrap up here today, guys, the biggest threat to your health plan isn't inflation claims or compliance. It's likely the people that you're paying to manage the plan. And that's the hard truth, guys. It's your broker. It's the network that you choose. It's the PBM that you're doing business with. These vendors should be working for you, not working against you. So if you're looking for serious savings, you want to start with the broker compensation alignment. You're going to see about 1 to 5% in potential savings, moving away from commission to a flat or performance-based fee. And then you're going to want to look at your PBM. This is going to, again, be low-hanging fruit, guys. Savings potential here is 10 to 20%. And then finally, direct contracting would be the third step that I would recommend. Savings potential here is even greater, 10 to 25%. So this is where you can really dial up some serious savings. So that's it, guys. I've gone over just a few minutes. I apologize for those of you that have stuck with me. Thank you for sticking to the end. If you're curious about how you can apply this to your plan and you're looking to take action before your next renewal drops, let's book a health plan review. This is going to be a free 30-minute consultation. And what we're going to look at is what's working well, but what's not working well. And we're going to focus on where you're overspending. And we can help you uncover the overspend. No preparation needed on your end. And at the end of this call, we'll give you an alignment scorecard to share with your team. And this alignment scorecard's free if you book this review this week. So start saving by your next renewal, guys. Don't wait until you get the renewal. Also, a huge mistake that I see people make is waiting until they get their renewal to start coming up with a solution. Start now. You can find anywhere from 20 to 40% in total savings, guys. Don't hesitate to reach out to us and let's get a call booked. Thanks. Have a great day.